Good evening, everyone, and thank you for coming on into the room here. Well, we have a special treat. As you can see, we've got actually two physicians in this session. And so we're kind of fortunate that this evening you get three physicians, three incredible glaucoma specialists on the cutting edge, one from Atlanta. You heard from Dr. Garza. And we also have Dr. Inderpal Singh, who will be our next speaker in the Milwaukee area, and then Dr. Jason Bacharach in the San Francisco Bay Area. So we have all parts of the country or significant parts covered from a regional perspective. My name is Evan Hockman. I'm the commercial head of optometry for Glaukos. And if you don't know who Glaukos is, that's okay. We've really been in the interventional glaucoma space for about a dozen years, as well as the cornea keratoconus space. And you'll hear more about us as time goes on because our company has really identified the importance of optometry with our organization and what you do in the eye care space. And we've actually been increasing the size of our team and our sales force to be able to go out there and do as much disease awareness and education as possible. Glaukos is a team where we go first, and you'll see that with many of the products that we have. We try to be transformational, much like the physicians that we have right here. You can read the slides that we have here, but Dr. Inderpal Singh is somebody that's on the cutting edge and that works with all over the space of glaucoma. And you might have heard him speak before because he's world renowned in terms of his presentations as well as his knowledge of the space. And he works within not only the drop space for many years, but he's really transitioned into the interventional glaucoma space as well. And he was also voted America's best doctor for many years. He works very closely in the optometry community. In fact, he's got somebody on his staff that is highly interventional as well, Dr. Jeff Banis, from an optometric perspective. So that's Dr. Paul Singh. He'll be our first speaker, and we will just be doing a handful of slides and then taking questions. And then we have Dr. Jason Bacharach, who is really a trailblazer, came on out from Philadelphia years ago and opened up probably in one of the most beautiful places of the country, in the wine country of Northern California, has an incredible practice that he had started and does a ton of research as well, and has worked with many companies in getting them off the ground as well, all within the glaucoma space. And so we're really fortunate to have both of them who do know each other, play very well in the sandbox, and that's why we have them both. So it's kind of a special time. So what I'd like to do is hand over the reins to Dr. Inderpal Singh and let him get going.
Awesome, awesome. Well, thank you, Evan, for that introduction. Thank you for letting me just be a part of this. Jason, awesome to hang out with you, my friend, out there in California. And I'm here in my home studio, actually here in southeastern Wisconsin. And really awesome presentation by Dr. Garza. That was really good stuff. And I think we're going to kind of dovetail off of what he was talking about with his collaborative care and early intervention. People ask me all the time, kind of what does interventional glaucoma mean? Do you have to do surgery? Is it about a surgical, issue? No, it's not about surgery. It's about a mindset. And Jason and I are going to talk about how we approach glaucoma now differently than when I came out of fellowship back in 2004. I'm old, my friends. But I remember when I came out of fellowship, it was like, well, I'm just gonna do drops, maybe a laser, more drops until they're really bad. Then I'll do a trap. And you know what? Deal with it. Suck it up, kids, because you're gonna have to take drops and suck it up because we had nothing more to do. But now we realize, what we can do? We can actually control pressures, get rid of compliance issues, and do it safely. It's not one or the other anymore. And to me, that's kind of the heart and soul of interventional glaucoma. Real quick, Jason, what about you? What does interventional glaucoma mean to you in your practice?
Well, first of all, thank you for hanging out with me, Paul. Paul is a great longtime friend, a as Evan said, a true trailblazer. Real honor to be here with all of you. I know it's late at night. We're going to make this interactive and fun. In this next 20 or 25 minutes, by all means, jump in, ask questions, any question you want. But surely, the focus is on glaucoma. Interventional glaucoma to me it's not cachet, it's a mindset. It's not a procedure. It's being proactive. And honestly, for me, that starts with diagnostics and then it moves on to therapeutics. And I'll just say that that transition is occurring if you look at young ophthalmologists in the ASCRS. Paul and my very good friend Nate Radcliffe just published this. Our glaucoma subcommittee of the ASCRS looked at what ophthalmologists in an avant-garde society are doing. about 50% are starting with drops still, maybe a little more, but it's slowly changing. The younger ophthalmologists, they're starting with SLT, as Dr. Garza said, and a lot of people are moving into procedural-based pharmaceuticals or MIGS procedures early on. So mindset, Paul.
I agree with you. And one of the reasons why I think we're seeing this push, this interventional mindset, why we see such a proliferation of technology in the laser world, the pharmaceutical world, as well, of course, into the MIGS world, is because we understand the issues we have with poor compliance. It is very difficult to keep people on these medications long term. And so, really, if you look at a lot of the issues that we face, it's really compliance. Probably the number one issue I face in medical management of glaucoma is compliance, and how do you keep people on drops for the rest of their life with costs and side effects and comorbidities like dry eye and just physical, issues as well. It is really tough. And, if you look at data out there, I think what's so nice about the light trial, what it showed us is that despite the same efficacy between drops and laser, yet drops tend to have more risk of progression than laser. And part of that could be just the compliance related part of it as well. And if you look at even MIG studies like the Hydrus and iStent and all these other ones, we see that there's a lot more data coming out showing us, despite IOP, if you have more stable IOP, you take the hands out of the patient and let the drops work 24 hours a day. I mean, the medications or the surgery work 24 hours a day, you tend to have less progression. And I mean, I could tell you, this is something that is the bane of my existence, Jason. Every single day, I see about 80, 90% of patients with ocular surface disease, hyperemia. And we think they don't matter, but they do affect compliance. And to me, that's probably one of the biggest issues I face. What are your thoughts? I mean, is that a big issue for you in your practice out in California?
The happiest patient, and many of the doctors on this call know this already, is the streamlining of drop therapy. No question about it, whether it's comorbidity with drops for ocular surface disease and dry eye and glaucoma, or just glaucoma. And I invented this term because I took the term MIGS from me, but I invented
I love
this
the term.
term and it's called MIDS,
I love
minimal installation drop strategy. It doesn't mean drops go away. I think Dr. Garza nailed it when he talked about bridge therapy or an adjunct. So drops don't go away. But like, Paul, you said when we started, it was drops, 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 and then SLT. And you know what? SLT never really worked that well at that point because of all the pathology to the TM from benzalkonium chloride, preservatives. So for me, if you take one thing home from this is alternative delivery system of pharmaceuticals and MIDS, minimal insulation drop strategy. Keep it in mind every interaction you have with a patient.
Yeah, and honestly, if you think about data on, when we use, let's say, MIGS procedures as SLT, the earlier we intervene, the better chance we have of those medications or these surgeries working because the target pressure tend to be not as low when you have more mild to moderate patients. But number two is that, the mechanism, when you have fibrotic TM, when your outflow system's messed up, a lot of the MIGS procedures don't work as well, which is why early adoption of stenting and, conventional MIGS, as well as utilizing some of these medications we'll talk about, can help. And when you have BAK and chemicals on the surface of the eye, and not only can it affect the surface in terms of dry eye, it can cause trabeculitis, scarring of the trabecular meshwork. And if you need to do a trabeculectomy later on for some reason, or a subconjunctival MIGS, like let's say a Zen, if you have patients on drops forever and their conjunctiva is scarred, you get a higher rate of failure as well. So this is kind of why we're trying to, yes, we needed drops, but if we can do drops later on or use them as bridge therapy before our other procedures, that's the idea. And for me, also, what's important about kind of this journey of MIGS and journey of interventional glaucoma, it's not any one procedure that's going to be enough. I tell my patients all the time when they first come to my office, like, look, my job is to keep you at the highest quality of life and protect you from getting worse. It may require one, two, three different procedures over the course of your life. We'll see what happens first. And depending on your anatomy, any one procedure may or may not work for you. And that's okay. We have other things we can do. So I set them up from the beginning that you're probably going to need multiple different modalities of treatments to get to the stage that we can protect you. And that kind of initial discussion really has helped a great deal in kind of how we describe it. And so I think we talk about interventional glaucoma and the benefits. It's not about doing surgery, as Jason and I just talked about here, but it's about understanding compliance is an independent risk factor for progression. I think now we have data that really does help understand that. Number two is that we realize what is safety. I mean, are drops truly a safer options topically, right? And again, I'm not bashing drops. I use them all the time, believe it or not. But I do think that we have to recognize that the side effect profile of drops, whether it's lash loss, whether it's meibomian gland dysfunction, fat pad loss, ocular surface disease, goblet cell density loss, all that over time can have a higher risk of comorbidities and affect on the quality of life than doing a procedure like an SLT or a procedural pharmaceutical as well. And so I think now we do have the opportunity to maintain a high quality of life for our patients, which we never had before. As Jason mentioned, some of the happiest patients are the patients who we get off of medications. And you don't realize it until you actually now ask these patients. Before we had these opportunities, we weren't asking patients, hey, do you want to get rid of drops, or do you like taking the drops? Because we're like, too bad, that's all we got. But now that we have these opportunities, we are asking patients. And last thing I'll do before we move on is, we were part of a study with the iStent inject, which is the combination cataract with the stent versus the cataract surgery alone. And what we found in that phase 3 trial, which we published that with Tom Samuelson and Blake Williamson, was that when you have patients who had the cataract with the stent, we found that we had better improvement in people who are not only off of drops, better improvement in their dry eye and in their reading and their driving at night. And it had to do with the reduction of drops. So we had better quality of life, which translated to better performances in their daily functionality. So getting people off of drops is not just about the pressure, it's about really maintaining a high quality of life for these patients as well. So with that said, we have a lot of opportunities and obviously MIGS, but the drug procedural pharmaceutical world, which you've heard about with Durista and now with iDose we'll talk about, has really made a huge impact in our practice. I want to let Jason talk about that in a second. But for me, this has become my practice pattern. It's really now down the bottom, from topical drops to add more drops to SLT to maybe a trab or a tube like we had up top. Now it's really down below. It's saying, look, let me do an SLT. Let's address the pathology directly. SLT addresses the pathology of the trabecular meshwork being majority of our risk or our barrier to outflow. And then we now introduce, if SLT is not enough, which it isn't for everybody, and that's okay. A, it doesn't work for everybody. Number two, sometimes our target pressures are lower. That's when I'll start to introduce now procedural pharmaceuticals, drug delivery, like we'll talk about the iDose, or you heard about earlier Durista, and I'm sure in the future other products coming on market. And then we talk about minimally invasive glaucoma surgeries, whether it's a standalone, let's say someone's young, a 50-year-old patient who's phakic, I'll do a canaloplasty or put something else in there, or at the time of cataract surgery, put a stent at the same time, let's say at the cataract surgery. And then we have other things like Zens and MIBs and lasers and everything else. But the bottom line is drops are there as we need them in between these therapies or as an adjunct to whatever we do with SLT, procedural pharmaceuticals, or MIGS as well. And so I'm going to kind of stop there, Jason. I want to let you talk about this and then go to the next slides. But what are your thoughts on this? Is this change? Is your practice patterns changed since you started out practicing a few years back?
Oh, oh my God.
I'm just
Like,
setting you up, man. I'm just setting you up. That's all.
yeah, like, obviously, I mean, like night and day. So the metamorphosis is sometimes you don't notice it until after when you look back, say, wow, how have things changed? There was a very interesting question that came into the chat, Paul. One of the docs on the line asked if somebody had an eye stent, let's say you did it during your phaco, and now would you still consider eye stent inject if they already had eye stents in there?
Good question. If they already had an iStent in there, it depends on two things. And I hate to say this, but if they were placed correctly, sometimes the stents aren't placed in the way you want it to be. Sometimes they can be placed not in the trabecular meshwork or in the canal as well. To see how far apart they were. So what we're realizing now with stenting, especially the iStent, is the more kind of surface area you have, the more we can access the collector channel, the better chance we have of getting a reduction of pressure because we don't know where those collector channels always are. So I guess to answer your question, in some situations, I have done that and I would do that and maybe get them further away from the ones that were already there. So I have more of an area that I'm addressing and make sure that they're in the right spot because I've seen some of my stents maybe not placed in the perfect spot as well. So I have done it in some occasions.
Okay. All right. Well, let's do this. Let's move into some really cool stuff right now. And um, that's the iDose. And I'm just going to spend at a super high level. Now, I can't speak as fast as Paul. So,
All right. All right.
Paul and I have been on many panels together. And I usually let Paul go first because he really wows the crowd. And I'll tell you, so what I usually do is I'll give you a bullet point or two from each of these few slides. But they're going to be take-home key points. We'll talk about them, ask a question. I see some more questions coming in. But really, this is for you so that when you go back into the office, if you're a patient, under, doesn't understand iDose, if you want to give an explanation, I love it when my co-managing optometric partners, colleagues, sister-in-law, my sister-in-law is an optometrist, anybody that is trying to help a patient understand this better and reducing the onus on me. I love that partnership. So it's a two-way street. It's good for everybody. And this technology is just insane. The most important thing, who not to use it in. I mean, none of us want to get in trouble. So if you had somebody that had right now, at least for right now, until we see some phase 4 studies, somebody that has like corneal endothelial issues going in, it's probably not, smart to offer this as a technology yet. We got to wait and see what happens with time and some phase 4 studies on that. And also if the angle's really narrow. Now, a lot of times if the angle's narrow and you're combining it with a phaco, the angle will open up real nice after the phaco, and then you can still do an iDose. But those would be the two big ones for me. It is just incredible technology. If you think about it, this device, and by the way, just making this slide was onerous for the company, for the sponsor tonight, Glaukos. This little device, under 2 millimeters in size by 0.5 millimeters, delivers approximately 3 years of pharmaceutical product. Patient today came in and said, well, what happens when it wears off? The instantaneous thought is, well, you got to go in and remove it. And that could be what we call fake news because you don't need to go in and remove it. You could leave it there. I have, and so does Paul, have patients have these in their eye all the way from the phase 2 studies, which occurred many, many years ago. And their eyes have been, absolutely quiet. But it does make sense if they love it. A lot of times patients will say, I want another one. And so we are looking forward to the day when iDose has a second time on-label indication so we can offer that. And that is in the works by Glaukos to make that happen. Not yet. Here's the secret sauce. When you look at this device, the secret sauce is right in the middle, and it's that nanoporous, semi-permeable membrane that allows the medicine from the aliquot, from the container that it sits in, a very concentrated travoprostic oil. Travoprost is the most effective prostaglandin, PGA, for the efficacy versus concentration known. And they're from studies done in the drop world. So it's a very efficacious concentrated travoprostic oil that slowly, at a steady state, is delivered through that semi-permeable membrane into the anterior chamber. That's the basis of how this works. And it's taken over a decade to develop this. Long-term commitment from our partners. Paul, I've heard you speak to this slide many times about, benefits. You've done some studies in your practice looking at drops and how expensive that is for your practice to write drops. A lot of this is aimed at the patient side, but I'd love for you to comment. I mean, I think all of us know, non-compliance and irritated eye, the polypharmacy and issues on the ocular surface. But from a doctor's standpoint, from a small businessman's standpoint, can you share a little bit of, at a high level, what you found in that study?
Yeah, I mean, it was pretty fascinating. You think about we actually lose money trying to write prescriptions for drops. And really, if you think about the time and the FTEs, our staff that are trying to deal with drop-related questions from patients, it's really pretty remarkable. We did a study where we found that for every drop that we reduced from the drop burden for the patient, we were able to save about almost 5 minutes of tech time per patient per visit. Basically, think about it. We monitored patients before and after they had a procedure done and how much time it took for our staff to answer questions from pharmacies, from the patients, from the callbacks. When you're at the follow-up visit, are you verifying? Are you on the right medication? Do you need a refill? Generic versus brand name substitutions. All those things that we deal with every day add time. And what was even more interesting, Jason, we're trying to look at now is the time and the decision making from the surgeon. So from you as a provider out there, optometry, ophthalmology, how much more time do you take to make a decision if someone is progressing, if they're on a drop versus off a drop? If someone's on a drop, right? You're thinking about compliance. Was it the right medication? Should I do a brand name versus generic? Should I add drops, right? All of a sudden, you're spending time thinking about that. If someone is not on a drop and they're getting worse post SLT, post MIGS, you have a clear decision. they're getting worse. I got to do something. Let me add a drop now or do something more, right? So your decision-making process is so much faster. So long story short, I think you're absolutely right. Yes, from the patient perspective, it makes sense to do this or to get them off the beds. But when you look at the staff and you as a provider, it makes so much sense from an efficiency and decision-making process as well.
Yeah, I appreciate that. We're getting hot and heavy on the questions, which is great. It means people are super interested in this. We'll do it quickly. We'll just hit a couple of quick questions here. If a patient had an allergic reaction to travoprost, itching, redness, is it a contraindicated for an eye dose? I will take that one because I have done eye dose in these people. 99.9% of the time, this is a tolerability issue to the drop. In the phase 2 study, we dosed one eye with the drop and we put the eye dose in the other eye. By the way, we did that with Durista as well. It was amazing the difference. The hyperemia, the prostaglandin associated periorbitopathy, the differences between intracameral placement and topical placement is tremendous. So, no, it's not necessarily the
Uh-oh.
next question, the Paul, I don't know if Paul can see it. Um, how do we balance providing proactive care based on the latest clinical research with limitations? Insurance, great question. For example, current research may support more frequent field testing, but insurance only lets us cover 2 to 3 times a year.
Well, I think that's a great question. I mean, look, there's some limitations no matter what we do with certain products and patients' access to coverage. It's going to be real. But at the same time, I think there's a lot of opportunities to do what you think is best for the patient. A lot of times it is a discussion with a patient if it is something that is going to require out-of-pocket expense. Sometimes I'll tell them, look, this may require an out-of-pocket expense, but this is the best thing for you. Sometimes you have to fight, do PAs if you need to, or, kind of look at other ways to get things approved as well and get support. But I mean, nowadays, I think we have options and we have different ways of approaching the same condition with different ways as well, different techniques, different technologies as well. But it can be an issue, but I think we have options now. That's how I approach it.
I will tell you from a visual standpoint, and by the way, Glaukos is heavily, heavily involved in all aspects of glaucoma. They are now a pharmaceutical company. They have been a surgical device company. They have a strong presence in Radius technology, which is an automated VR headset for excellent visual field results. They really have made their mark in glaucoma. And of course, now they're involved in the retina and cornea. So Glaukos is becoming a huge partner. Just the fact that they've launched an optometric division and really want to partner is super cool. And it's just a wonderful company to partner with, as Paul and I know from our years of working with them.
And recently they also are now working with mitomycin company Mobius to give us some help with our trabeculectomies and our Zens now, my friend. So they're even into that extreme now, which is cool.
No question. And by the way, regarding that, that's something that you should have a conversation with your surgeons about. What kind of mitomycin? Are they using a compounded pharmacy or are they using the on-label mitomycin that Paul just mentioned? So it's definitely something to learn about. Again, I'm going to go real high on these bullet part points. I'm going to pick one, and I'm going to pick one because I was honored to publish this study. And one of the things that we looked at in the study were people coming into iDose to get iDose that were on a topical PGA. So these were people on a monotherapy PGA, and it could have been any PGA, bimatoprost, travoprost, latanoprost, and they came into the study and we washed them out. Their pressure went up, and then we placed an iDose. And at the pivotal time point, at 3 months, their pressure was lower with the iDose. Time matched was lower with the iDose than it was with the drops. A lot of questions. Maybe they weren't compliant with the drops. Maybe it's the high concentration at the TM. But bottom line is the efficacy is proven here. And a wonderful, combination of efficacy and safety. A summary slide, I always like to end on safety because, we take care of these people for, the rest of their lives. And, we're community-based doctors like all of you. And in fact, I sent a picture of one of Paul's dad's patients to him last week
That was
that,
awesome.
that Paul's dad had cared for in his practice decades ago. Endothelial cells. The wonderful thing here is that with this device, and I know Dr. Garza talked about endothelial disease and worsening of the endothelial cell count with multiple, for example, Durysta. Durysta is a super important product, but if you're placing multiple Durysta in the eye and they're stacking up, you can get endothelial cell damage. With this device, because of its stable platform in the angle, we have 3-year data now showing stable in the lower right of your screen. It was essentially the same as the Timolol control ring. So these devices rarely need to be explanted. You can use them all along the continuum of the disease. And we're going to show you one video as we close here and take any more questions. Paul, do you want to walk us through the video? I believe, is this one mine or yours?
That's your video. You want to walk us through it, but we can both comment on it. I mean,
I mean, this is a
this is
very
yours.
standard placement. We're doing it through a gonio prism. The device, like I said, was 1.8 by 0.5 millimeters. I'm doing this under topical and intracameral anesthesia. We have an injector that's ergonomic. We release the device. It is implanted into the scleral wall. So we know that that is absolutely fixated to the scleral wall through the trabecular meshwork. And I tap it on both sides that you'll see here just to make sure it's stable and in position. I believe Dr. Garza showed a picture of one earlier. It's not unusual to see a tiny little bit of heme coming from the angle, but that's a nice stable implant there. Paul, why don't I turn
Yeah,
it over to you to close and give some comments here?
yeah. Actually, why don't you play my video while we're doing closing comments? Because I have some comments on that too as well in terms of how it relates to my ending. But basically, if you think about, one of the reasons why we get stressed out about doing glaucoma surgery is, are we going to get the efficacy? Are we going to deliver on the promise? Is my video playing next?
While they're bringing up the video, Paul, one
Okay.
doctor asked, do you check endothelial cells before iDose?
I don't, because I think the data that we found what Jason was presenting shows us really st good stability of the endothelial cells. I don't check endothelial cells unless I was going to for other reasons, for like I say, a Fuchs dystrophy patient, which I wouldn't do this in pretty much. So I don't actually. How about you?
Same.
Yeah, I think we're pretty I think confident with the stability there. But what I think is really cool about the iDose specifically is it hedges our bets. Right, here's a patient I'm doing cataract surgery on, and there's those three iStent infinites. Those are the three stents. I'm putting an iDose at the same time my cataract and my iStent infinites. So here's a patient where I'm able to now help outflow with three stents. And I'm also helping the uveoscleral pathway by putting an iDose in there. You can see how stable that is. And it's kind of cool to see the iStents and then this iDose in between. And I think this is also important for something called standalone, right? One of the things we're not seeing yet is a significant growth in the standalone MIGS market. Are people going into surgery not at the same time of cataract surgery as you see here, but just to go in there just for the glaucoma, just to put the iStent or do a canaloplasty or a goniotomy? I think there's a lot of fear from a lot of our surgeons. Am I going to get the results I want? Am I going to reduce the pressure or reduce the drop burden? And if I don't, is a patient going to get mad at me? Well, I think what the iDose has done for me personally, Jason, is it's allowed me to hedge my bets. Where now I feel like, okay, I can put my stents, do my canaloplasty, and I can put the iDose at the same time to get that PGA in there for 2 or 3 plus more years. So I know at least I'm going to get that PGA effect as well. So I'm much more now comfortable going into surgery as a standalone as well, not just for the cataract surgery. So I think as an adjunct to everything we do in our MIGS world, the iDose has really helped me a great deal. And I'll just close by saying, let's not be complacent. I can tell you this, and this is not just a commercial for me. I remember so many years with my dad when my dad would say, "How is glaucoma doing, son?" And I'm like, "Oh, glaucoma's great, Dad." He'd actually say in the Indian accent, "So tell me, how is glaucoma doing?" And I was like, "Dad, it's so easy. No one's getting worse." And then like 5 years later, the same patient comes back in. My dad's like, "So how is glaucoma?" And I'm like, "It sucks, Dad," because people get worse on you. It's just like this. You just wait for the cliff and it's bam. So I just learned now after getting burned by a lot of people in my career, a lot of patients, unfortunately, that let's not wait till it's obvious progression. Let's not wait till they're obviously fluctuating or the pressures are spiking up. When we see compliance issues, we know there's compliance issues. Let's address it. Now we have so many tools, whether whether it's laser, drug delivery, MIGS, and great new medications also. Let's try to minimize mids, as he said, the drops, use them, but use these other technologies to help the quality of life and decrease the chance these patients getting worse. Because when they do get worse, it is hard for both optometry and ophthalmology to take care of. That was my closing.
That was great. Guys, thank you so much. We appreciate it. I think you can hear the applause from all over the country. I want to thank all of our audience for staying with us for both groups, but to have three glaucoma specialists is fantastic. If there's anything that we can do from a Glaukos perspective, please reach out. My name is Evan Hockman, and I'm on LinkedIn. And you can find me, and I can put you in touch with our local folks if you're not already. Thank you very much, and have a great evening, everyone.
Thanks, guys. Great job. Take care, everybody.